Welcome to this educational video on the approach and management of facial injuries. My name is Jennifer and I am part of the MD class of 2021. I have made this video with Dr. Janine Roller, a plastic surgery resident at the University of British Columbia. In this module, the learning objectives are as follows: to review basic craniofacial anatomy, including relevant bones, vessels, and nerves, to go through the general approach to craniofacial injuries, and to review the management of common craniofacial injuries. First, we will review the pertinent craniofacial anatomy. There are 8 cranial bones and 14 facial bones. The bones of the cranium include the frontal bone, the parietal bones, the temporal bones, the occipital, sphenoid, and ethmoid bone. The facial bones include the zygomatic bone, maxilla, lacrimal bone, nasal bone, inferior nasal conchae, vomer, and mandible. Knowing the vascular anatomy is critical in trauma scenarios and when performing dissections for reconstructive cases. The branches of the external carotid from inferior to superior are the superior thyroid artery, the ascending pharyngeal artery, lingual artery, facial, occipital, and posterior auricular artery. Next, we will highlight some of the key nerves that can be involved in craniofacial injuries. The trigeminal nerve, cranial nerve 5, is divided into 3 branches and provides sensory innervation to the face. V1, the ophthalmic nerve, V2, the maxillary nerve, and V3, the mandibular nerve. Damage to these nerves and branches results in altered sensation or numbness to their respective areas on the face. The facial nerve, cranial nerve 7, provides motor innervation to the face. The branches of the facial nerve include the frontal, zygomatic, buccal, marginal, mandibular, and cervical nerves. It is also important to know your cranial nerves as a whole, as testing for these will be necessary for a complete craniofacial exam. Now let's go through a general approach for a craniofacial injury consult. Craniofacial injuries can occur as a result of large trauma and patients can be quite unstable, so before starting, make sure to apply your ABC principles to ensure that the patient is stabilized prior to getting a thorough history. A full craniofacial history will help elicit the patient's symptoms and anticipate the injuries they have. A methodical approach can be helpful to ensure you don't miss any pertinent information. This includes documenting the mechanism of injury, if there was any loss of consciousness, neck pain, or other symptoms consistent with a concussion. This will help determine if there is any concern for an intracranial injury or a C-spine injury. Other information that you should get on history includes changes in vision, including double vision, hearing, or smell. It's important to note if the patient has any new, loose, or missing teeth, and if their occlusion is normal. Remember to also ask about past medical history, surgical history, medications, allergies, and obtain a thorough social history, including alcohol intake and smoking status. The next step is to conduct a thorough craniofacial exam. There are many ways to approach this exam, but the most important part is to be consistent and thorough to ensure nothing is missed. To start, the vitals and C-spine status should be noted. A top-to-bottom approach can be used to evaluate each critical structure. Starting at the top, the globe should be visualized and the visual acuity, extraocular movements, and pupils should be examined. When examining the nose, it's important to determine if a septal hematoma is present. During the ear exam, make sure to document if hemotympany is present. From a bird's eye view, review the patient's facial width and projection. Also, palpate along the facial bones to look for any signs of increased tenderness or step deformities indicating a potential fracture. During the intraoral exam, document the patient's oral hygiene status, dentition, disruption of the oral mucosa that may indicate an open fracture, mouth opening, and the occlusion. Finally, make sure you conduct a full cranial nerve exam. After completing your physical exam, you may want to consider certain investigations to aid in the final diagnosis and prepare for a potential OR. Trauma blood work, including CBC and a Gruppen screen, are important and should be done. Imaging for craniofacial injuries include a facial bone CT scan that includes the mandible. Now that we have a basic approach, let's go through the most common craniofacial injuries and how to manage them. A nasal fracture is the most common craniofacial injury. The severity of a nasal fracture varies depending on the mechanism of injury and the extent of the displacement. On history, it is important to note if the patient has previously had a nasal fracture or any prior nasal surgeries. On physical exam, check for and drain any septal hematoma. If left untreated, it may lead to permanent deformities, a source of infection, or cartilage necrosis. Orbital fractures occur in 20% of facial fractures and are described by their location, the roof, floor, medial, or lateral walls. You can also note if the orbital rim is intact or not. An orbital floor fracture that permits herniation of the orbital contents into the maxillary sinus and is entrapped by a green stick fracture resulting in pain with extraocular movements and limited upward gaze is consistent with orbital entrapment. Pediatric patients are more prone to orbital entrapment due to the increased elasticity of the periosteum in comparison to adult bones. This results in a trapdoor-like mechanism where recoil of fractured orbital floor entrap orbital contents within the fracture line that can result in ischemia and permanent diplopia. Management includes consulting ophthalmology to evaluate the eye and determine the presence of a microhyphema and provide guidance on the safe timeline for operating if required. Surgical intervention is indicated when there is ongoing diplopia in functional fields of gaze within 2 weeks, if the defect is greater than 1 cm squared, if there is enophthalmos greater than 2 mm, or clinical evidence within 6 weeks of injury, entrapment, or retrobulbar hematoma. If surgery is indicated, determine and document sensation in the V2 distribution, which is a common medico-legal issue. The zygoma articulates with 4 bones: the frontal bone, the maxilla, the temporal bone, and the greater wing of the sphenoid. On history and physical, it's important to note of any infraorbital numbness, subconjunctival hemorrhage, facial asymmetry including malar flattening, any step-offs along the orbital rim or arch, and any trismus from zygomatic arch impingement. The goals of management include restoring facial width, projection, and to restore the orbital volume if it has been affected. Minor deformities can be treated conservatively. Operative indications include deformity, orbital entrapment, enophthalmos, and trismus. In isolation, a zygomatic fracture can be treated up to between 5 to 10 days post-injury once the edema has receded. Maxillary fractures can be classified using the Laffour system. A Laffour type 1 is a transmaxillary fracture through the anterior and lateral maxillary walls. This pattern separates the inferior maxilla from the midface. Laffour type 2 have a pyramidal fracture pattern. The fracture traverses the nasofrontal suture, the nasal process of the maxilla, the medial orbital wall, the orbital floor, and inferior orbital rim. It also goes through the zygomatic maxillary suture and posteriorly through the pterygoid plate. Laffour type 3 fractures result in craniofacial disjunction. It traverses the nasofrontal suture through the frontal process of the maxilla, down the medial orbital wall and floor, across the zygomatic arch and pterygoid plates. Laffour fractures can be managed non-operatively or operatively. Non-operative treatment is rarely adequate and is only used in specific situations such as an edentulous patient. Operative management focuses on restoring facial height and width in addition to occlusion. Mandibular fractures are common after physical altercations or motor vehicle accidents. On exam, the following should be documented: dentition, pain on palpation and with jaw movements, trismus, occlusion, and deviation of the mandible with opening and closing. Ecchymosis of the floor of the mouth should also be documented and looked for, as it is pathognomonic for a mandible fracture. A CT scan will be able to provide additional information about the fracture pattern. Non-operative management includes close follow-up and a soft diet, which is indicated in minimally displaced, stable fractures with no change in occlusion or range of motion. Operative management can include maxillary mandibular fixation by using arch bars or posts with elastic or wires, or open reduction internal fixation with plates. An open fracture is defined by a fracture that involves the teeth, goes through a tooth root, or opens to the gingiva. These are managed with antibiotics and mouthwash in addition to surgery. The last type of craniofacial fracture we will cover is a panfacial fracture. A panfacial fracture involves the upper, middle, and lower thirds of the face. In these cases, going through your ABCs takes priority before proceeding with any other procedure. Once the patient is stabilized, the general principle to guide the management is working from stable to unstable. This can result in a top-to-bottom or outside-to-inside approach. This concludes our video on the basic approach and management to craniofacial injuries. The attached video reviews what we talked about today and will help consolidate the information reviewed. Thank you so much for watching and best of luck on your studies.
Patients with facial injuries often have multi-system trauma. As such, your initial assessment should follow the ATLS or Advanced Trauma Life Support Protocol. First and most importantly, assess the airway of the patient. Facial injuries increase the risk of upper airway obstruction from swelling, broken teeth, and/or uncontrolled bleeding. An obstructed airway can be fatal, and managing this should take precedence. After the airway has been protected, the second most important thing in relation to facial injuries is to clear the C-spine both clinically and radiologically and to rule out a skull fracture. Basal skull fractures can lead to significant intracranial trauma, which can be life-threatening. In addition, the operative management of facial injuries requires manipulating the head. Making sure there is no C-spine injury prior to surgery is vital to the safety of the patient. Once the patient is stable, assess the extent of the facial injury and develop an appropriate management plan. For simplicity, there are two components to facial injuries: soft tissue and bone. If there are any facial lacerations, they should always be cleaned and sutured closed. With regards to bone, think of the face as a puzzle with 5 main bony pieces: the nose, zygoma and orbit, mandible, maxilla, and the frontal sinus and skull. The most frequently fractured piece is the nasal bone. If you see a patient with a nasal fracture and septal hematoma, always drain the hematoma. Not doing so can increase the risk of septal necrosis and perforation. Nasal bone fractures can often be treated performing a closed reduction and nasal packing. Zygoma fractures are the second most common facial fracture. These are often due to direct trauma. Don't forget to assess vision. Most of these patients will also have concurrent ocular injuries. If the patient has an orbital floor fracture, make sure there is no entrapment of the inferior rectus muscle. Entrapment is a clinical diagnosis and the patient is unable to elevate the eye. This is a rare surgical emergency most commonly seen in the pediatric population. Mandibular fractures occur less commonly but carry the increased risk of airway obstruction secondary to swelling and teeth displacement. Fractures of this bone can cause malocclusion, numbness in the V3 distribution of the trigeminal nerve, and temporal mandibular joint problems. If malocclusion is present, prepare for early surgical intervention.